good afternoon, good morning, or good evening, or wherever you welcome to the Heart Failure Policy Summit 2024, Session 1, Heart Failure as a Top Priority, the Road to Political Commitment. My name is Ed Harding. I am the Network Director of the HFPN, and it's my great pleasure to be your chair for this session today. Before we go any further, I'd like to acknowledge our kind sponsors, AstraZeneca and Roche Diagnostics, who have made the summit and the work of the Heart Failure Policy Network possible. A huge thanks also to all our speakers, quite a stellar lineup, as you'll see, who give their time for free. Quick reminder about us. Many of you will know who we are already, but in case you don't, the Heart Failure Policy Network is a multi-stakeholder platform formed in 2015 with the aim of driving political urgency in heart failure. Don't forget to join us for our second session also on Thursday, where we'll be looking at some of the potential new research, advocacy, and clinical innovation. Next slide, please. Brief reminder that the summit is part of our service to the global community. It aims to clarify, in the context of 3 hours of the summit, some of the critical questions that are at the heart of changing the future of our healthcare systems to improve patients' lives, prevent heart failure cases. All those who care about that, the summit intends to be your place to go once a year to hear from some of the most exciting commentators and leaders in this field. So, to open the summit, we're keen to hear from you directly and to get a sense of the utilization of heart failure in your country. So we will now launch a brief interactive poll. We'd be grateful if you could please take a moment to respond. Our poll is as follows: which benefit of improving heart failure care is most likely to encourage investment from policymakers? Which will resonate with them the most? Healthy aging, arguments of decreased healthcare costs, arguments of workforce productivity, or what a narrative of increased healthcare system sustainability? In question 2, we'd also take your view on the degree to which coordinated action with government has changed things for the better. Have you seen a significant increase in government attention and policy attention? And whilst you're doing that, I'll give you a bit of time to respond. Just some brief housekeeping. If you do encounter any technical problems in the summit, please do reach out to the HFPN team. The email has been posted in the chat box. They will help you. You can turn on auto-generated subtitles by clicking on the option bottom right. Please remember to post your questions in a Q&A box throughout the webinar. Try to answer them towards the end of the session or to collect them for follow-up. So thank you for those replies. We'll come back to some of the answers later on. What we'd like to do now is to kick off with part 1, which is heart failure in an evolving policy landscape. It's critical that we are able to present the case of change for heart failure to those at the very top levels of decision-making in our society. To that end, we are honored to welcome Minister Monica Garcia Gomez, the Spanish Minister for Health, to formally open the Heart Failure Policy Summit 2024.
Ladies and gentlemen, good morning and welcome to the Heart Failure Policy Summit. Before we begin, please allow me to extend my sincere apologies for not being able to join you live today. However, I am deeply committed to the cause we gather for today, and I am grateful for the opportunity to address you through this pre-recorded message. Here we are all aware of the enormous problem that heart failure and other cardiovascular diseases pose for our healthcare system in the 21st century. In Spain, heart failure is one of the most common chronic diseases, and its prevalence increases with age, with 17% of the population over the age of 75 affected. As we all know, our societies are aging, and therefore the number of people with heart failure in Spain will continue to rise as in other Western countries. Additionally, heart failure is a major cause of hospital admissions, further increasing the costs of the Spanish healthcare system. We are aware that the traditional risk factors of heart failure, such as diabetes or high blood pressure, do not explain all the burden of heart failure and other cardiovascular diseases in our societies. The degree of social inequality is one of the major drivers of heart failure and cardiovascular diseases. It is related to access to important resources for health promotion, such as income, housing, and the type of neighborhood where people live. Hence, addressing social inequalities within our societies is one of the most effective public health policies we can pursue. Not only the aging population and social inequality, but also other challenges we will face in the coming years, such as pollution and extreme temperatures due to climate change, are factors that will worsen the problem of heart failure and cardiovascular diseases in general. These three factors, aging of the population, social inequality, and if left unchecked, worsening climate change, will create significant strain on our healthcare system, particularly concerning cardiovascular diseases. In the context of these challenges, it is an honor for the Ministry of Health of Spain to present at this Congress our National Cardiovascular Health Strategy. This strategy has been the first strategy in Europe after the COVID-19 pandemic, and it has clear and perfectly measurable objectives. I will not go into detail about its main measures, since our General Director of Public Health and Health Equity, Pedro Gullón, will address them during this same Congress, and I don't want to spoil his presentation. Therefore, from the Spanish experience, we wanted to encourage the rest of European countries to follow our example and develop national cardiovascular health strategies based on quantifiable objectives and the involvement of the medical community and patients association. We, the Ministry of Health of Spain, will always be delighted to work with our colleagues and partners, collaborating wherever possible by sharing our experience and our most recent work in this regard. Finally, I would like to recognize the efforts and dedication of CardioAlianza, the Spanish Heart Failure Association, and the broader global heart failure community. Your tireless advocacy and efforts serve as catalysts for change, inspiring hope and driving momentum towards real outcomes. Also, I would like to express my support and esteem for the work of the Heart Failure Policy Network and the whole European Heart Failure Mission, and specifically for the organization of this summit. In conclusion, let us push our collective efforts toward we can forge together a path of political commitment with healthier population living in healthier societies. And we can all also commit to the development of more resilient and caring healthcare system in which heart failure and other cardiovascular diseases are top priorities. Thank you, and let the summit begin.
Huge thanks there to the Minister of Health in Spain for that fantastic opening. The Minister making there a very interesting comment about the belief, the wish of decision makers to see wider cardiovascular strategies in which heart failure is addressed. Some theme that we will come back to across part one of the summit several times. However, of course, speaking here to the specific heart failure audience, very important to know what exactly is in the plan with regards to heart failure and what some of those measures are. And to that end, I'm delighted to welcome Pedro Gullón Tosio, the Director General of Public Health and Health Equity at the Spanish Ministry of Health, as invited by the Minister to give us those further insights into how heart failure features in the strategy and what some of the next steps are going forward. Thank you so much for joining us. Pedro Gullón Tosio, over to you.
Thank you so much. Good morning, good afternoon, good evening, depending on the country that you are. It's really good to talk in this summit. I want to start by thanking all the people that have organized this Heart Failure Policy Summit. Actually, I'm really happy for being here, and also good to chat with other people that I knew before that now are in this summit. As it happens with most countries in the world, cardiovascular disease, and specifically heart failure, is one of the leading causes of death and disability in Spain. If we put that in numbers, the incidence of heart failure in Spain is more or less 2.7 cases per 1,000 persons a year. So it's quite high. Despite this, Spain is not the country with the highest rates of heart failure, and actually not the incidence but the mortality in heart failure has been decreasing in the last decades. But there are many challenges that we have to cover. As the minister has said before, we have implemented a national strategy on cardiovascular disease that was approved in 2022, so just a couple of years ago. And I want to talk about some of the challenges that we have in heart failure treatment, prevention, and recovery, pointing out some of the things that we are addressing in this strategy. When I do this, I prefer to present this as part of a life course of the disease and the life course of persons. So I will talk about before having the disease, when you are in the early stages of disease, then when you have developed the disease, and then some things that the health system can do about everything. So first, we have, before having any kind of disease, we have what people in public health, I know that cardiologists, they don't talk in the same language, but in public health, we call that primary prevention, what you can do before having any kind of signs. So the objective of all these strategies is to reduce the incidence of cardiovascular disease or heart disease. To do that, we need a strong focus on health promotion and risk factor prevention. That's for sure. However, we have to take into account some of the new challenges and the new strategies that have been put into policy of heart disease. For example, the social determinants of health approach, a health equity view, the health in all policies approach, and the effects of climate change that in a country as Spain is really is very important to take into account. In this sense, in Spain, we are experimenting some changes that will be seen in the next few years, some that are actually happening right now. First, we have recently approved, and it's so recent that it was last week, a new ambitious strategy for tobacco control and prevention that we think that for sure will have a strong impact on heart failure in the future. Second, we have created an observatory of climate change and health that now is redesigning all the heat alerts in Spain, and that's really important in terms of what will happen with heart disease in the future. That in people that have some issues of because they're older in age, that they are really vulnerable to heating and heat waves in Spain. Third, we are preparing a new law to introduce the concept of health in all policies in decision making, which will force, and that's what we want to do, we will force the different departments to do a health impact assessment in non-health policies. Okay, so if you want to do an urban policy and if you want to develop economic policy, you have to do a health impact assessment. That's something that will come in the next year, I hope. So after talking about primary prevention, which is trying to reduce the incidence by tackling social determinants of health, risk factors, etc., we now have people with early signs of health that we want to detect early. That's what we call in public health secondary prevention. I know that the term of secondary prevention with cardiologists is to prevent new cases when you have a previous one, but in public health we talk secondary prevention when we talk about the screening. Okay, so in this case, and it's part of our strategy, now we are evaluating which screening strategies are better that we can put that, and we have enough evidence for a population approach in secondary prevention, so just to offer that to the whole population, trying to reach all the population, or which ones are best as an opportunistic screening. So people that you have in the consultation, you think that might be suitable for that, and enter in this screening strategy for prevention. Actually, this is a very interesting point for public health. As we often people in public health and preventive medicine, we say that prevention is better than cure. But screening is something that is really complex, and we have clear criteria to know when the evidence suggests that a screening program exceeds the potential iatrogenic effects that can have on a screening program. So it's not something that you can do a screening for everything. So we need evidence and we need to fulfill these criteria. If we have not been able to prevent these cases, we need to have the best treatments and the best strategies to prevent death and to prevent major consequences. That's what we call in public health tertiary prevention, okay? So when you have some disease and you need to recover soon. In this case, I think that we have three main challenges that we need to address. The first one is how to incorporate the new technology and the advances of new devices soon, but with strong evidence. So just to be flexible, to have the evidence soon, and to incorporate these new technologies sooner in our strategies. Second, in a country like Spain, that we have a decentralized healthcare system, it is really important to improve the dialogue between all the people that are involved, especially our autonomous regions, and to do some coordination strategies. I've seen the question before. What do you think about how the coordination strategies have improved or not the treatment of heart failure? And I checked like slightly, or even it has worsened. It has worsened that. But we need to address that. It's something that is quite important for countries like Spain. Others that have a more centralized network, it's not the same. But for decentralized countries like Spain, that's something that it has to come in all strategies. And third, we have to incorporate all the learning that I have said before for primary prevention and also other pharmaceutical strategies to prevent the new events. That's what you and the people in cardiology, they talk about secondary prevention. Okay, so summarizing this, we have strategies to prevent new cases with primary prevention, to detect early cases with secondary prevention, and to try to better cure, and if not, to prevent new cases in people that have had a previous heart attack or a previous event before, to have new ones. That's the three main points of prevention, but also cure in the strategy. But also we have incorporated an approach for quaternary prevention. What do we mean by quaternary prevention? So all the things that we do in the healthcare system can do harm. That's something that happens. It can have iatrogenic effects. So we have included some measures that can evaluate what we do in the national healthcare system and to see where are the strategies, where are the things that we do that can do more harm than good. In this case, we have incorporated an equity approach in that. For example, we know that the effects of heart failure are different in men and women, and that's something that we need to cover in the healthcare system to train our professionals to see differences. And because right now we know that there are differences in treatment between men and women, and we have to reduce this gap. All of this is integrated in the National Strategy on Cardiovascular Disease that the minister has talked before. It's publicly available in the website, and if you look at it directly in Google, but I'm sorry, it's only available in Spanish. We might have soon one in English for people outside the country. We have begun with this strategy in 2022, and we will start with evaluation of some indicators really soon, because that's a strategy that will be long-term, and we want to do at least an annually set of indicators that for evaluating this strategy. So thank you again for the organization, and well, let's begin with more things. Thank you very much.
Thank you so much, Pedro Guillen-Tosio, for that incredible insight. The Spanish National Cardiovascular Strategy was widely recognized, I think, as one of the first truly modern cardiovascular plans since the pandemic, and fantastic to have your explanation there of the approach to heart failure across the different stages of primary, secondary, and tertiary prevention. I would encourage all on this to take a good look at that strategy as a real roadmap for what the national strategy can set out to achieve. And we look forward to hearing more about that. Continuing with the theme and possibly picking up on your point there, Dr. Guillen-Tosio, about the need for national leadership in regional systems, we're delighted to have with us Dr. Alice Borghini, who is Director of Digital Health and Telemedicine at the National Agency for Regional Healthcare Services in Italy, AGENAS. Dr. Borghini, thank you so much for joining us. And I know everybody on this summit call would be fascinated to hear more about the chronic disease strategy in Italy and how heart failure features.
Thank you very much for inviting me, first of all. And I'm in these 5 minutes, I will try to give you the state of art of the Italian vision for managing chronic diseases. Can we go to the other slide, please? After the pandemic, the Italian government approved the National Recovery and Resiliency Plan. The mission 6, which is the health mission of the Recovery and Resiliency Plan, use around 7 billion to reform the primary healthcare system. We all know that the primary healthcare system is the setting where chronic disease should be treated and where chronic patients should be treated. So the Italian government decided to invest, to do this big investment on the primary healthcare system and sector. Here you can see the redefinition of our primary healthcare, the main aim of this big investment is to ensure that people with chronic diseases receive continuous and coordinated care at their home, basically. The ministerial decree who defined this reorganization of the primary healthcare sector is the number 77 of May 2022. And this reform basically define new standards and new organizational model for the primary healthcare sector. Basically, here you can see this new reorganization where which is aimed to increase home care, using also telemedicine, decrease unnecessary emergency room visits, minimize long-term hospital stay, and address care access disparity nationwide. The decrees also emphasize the multidisciplinary approach, a proactive approach, and highlight the importance of social and health integration. And is based on the approach of One Health. As you were introducing me, I came from Agenas. Agenas is a national and technical body of the Ministry of Health. And we are also become 2 years ago the National Agency for Digitalization of Healthcare System. And that's very important because now we are trying to introduce a big digitalization of a healthcare system through this big investment on telemedicine, using also the artificial intelligence, and also incrementing the healthcare professionals' competencies on digital health. All those investments are basically, can we go to the next slide, please? Thank you. This investment is basically, all this investment is basically aimed to go through from a model based on services to a model based on taking charge through to the system of the patient, of the chronic patient in particular, using digital health solution. How I was saying before, Italy is going through a big digitalization of healthcare system through the introduction of National Telemedicine Platform, which is a platform of a governance platform, which also defines standards from technical point of view, but also from procedural point of view and organizational point of view. And everything is to hold the nation. Italy has a big differences from all the healthcare systems because they are basically regional based. But now we are trying to uniform these services also through this the national telemedicine platform. So all the investment in primary care are aimed to take in charge of patients in the different settings of healthcare systems, and using also an approach aimed to evaluating of performance and outcome of what the healthcare system provides. So chronic patients are our main focus right now in Italy, and in particular we have an investment also for specifics for chronic care failure, because we have invested and we are financing a platform, a specific service for the telemonitoring of chronic heart failure patients. So that's our state of art. Thank you.
Thank you so much, Dr. Borghini. I think what was so fascinating about this and the previous presentation was this glimpse of the future. And again, clearly we have here a next generation national plan for the management of chronic disease, where the community and digital healthcare services are going to be absolutely critical to the sustainable approach. And again, I would hugely encourage all in the heart failure community to look at this. We've had a lot of talk about, there's been a lot of push for management of care in the community, use of digitization. I think what's exciting here is that this can map onto a much bigger strategy. So thank you so much for joining us to present that. We very much appreciate it. And your country colleague, Salvatore Di Somma, will be presenting a bit more on Italy later on. Thank you. Continuing in the theme of senior commentaries on the next generation of national strategies, you may have gathered that Romania will be one of the next countries to release a post-pandemic cardiovascular plan. And to that end, who better to tell us about it than Professor Dragos Vineveanu from the Ministry of Health, who will give us a commentary there. Sadly, he can't join us today, but we're delighted to have his pre-recorded message.
Good morning. I am Dragos Vineveanu. I am Professor of Cardiology at the University of Medicine and Pharmacy Carol Davila from Bucharest, Romania. Today I have the pleasure to give you some information regarding cardiovascular diseases in Romania and our new strategy for the management of cardiovascular and cerebrovascular diseases. Cardiovascular diseases in Romania are responsible for more than 50% of the total mortality. In fact, cardiovascular diseases are in the first place, followed by cancers, in terms of general mortality in our country. We are one of the first 3 countries in terms of mortality and preventable deaths in the European Union. And the main causes of this mortality are related to acute coronary syndromes and stroke. Which are the main risk factors for cardiovascular diseases in Romania according to the last statistics of the European Union? In the first place are the dietary risks of about 25% prevalence, followed by smoking, 17%, and air pollution and alcohol consumption, 7% each of them. Last year, Ministry of Health, together with the professional organizations, initiated and finalized the elaboration of the strategy for health. This is for 7 years between 2023 and 2030, and one of the main objectives is the decrease of the cardiovascular mortality, preventable mortality in Romania by at least 5%. So we decided to have a strategy for management of cardiovascular and cerebrovascular diseases, which should complement the national strategy for health. We initiated this project together with the Ministry of Health, together with other professional and academic organizations 2 years ago, and now the strategy is ready to be issued as a government decision. The strategy of management of cardiovascular and cerebrovascular diseases was elaborated using the collaboration between the Romanian Society of Cardiology and the Romanian Society of Neurology. There were 5 working groups, and each of them concentrated on one of the main 5 subjects of the strategy. These subjects or chapters of the strategy are as follows. Prevention. Prevention is extremely important, and we are discussing primary and secondary prevention of cardiovascular and cerebrovascular diseases. Of course, treatment is one of the most important chapters, and we include a lot of objectives regarding treatment of these diseases for the next 7 years. Human resources are a very important problem in terms of distribution in Romania. The human resources, both for physicians and nurses, are concentrated mainly in the university hospitals. So, a good distribution of the human resources all over the country, it's very important, a very important point of the objective of the strategy. Rehabilitation. Rehabilitation for cardiovascular and cerebrovascular diseases is not very well represented. So this is also a very important chapter. And finally, research, mainly by having strong epidemiological studies, it's also an important issue, since Romania is one of the pilot countries of the EuroHeart project. So this strategy is going to be one of the first strategies in cardiovascular and cerebrovascular diseases in the whole European Union. Regarding heart failure, we have some major objectives. The first 3 most important objectives are related with the implementation of biomarkers in most hospitals in Romania. The second one is related to the reimbursement of ARNI, and the third one is related to the reimbursement of SGLT2 inhibitors for all types of heart failure. Thank you very much for your attention.
Fascinating to hear there from Professor Dragos Vinovianu as to the key provisions there in heart failure, and again, the wider citing of heart failure within a cardiovascular strategy. There's some very specific commitments there in human resources, biomarkers, reimbursement of iron and SGLT2I inhibitors. So again, one, I think, for the whole heart failure community to pay very close attention to if you are working for an improved national strategy in your country. Now I would like to turn to a series of presentations on the relevance of the European Union to cardiovascular disease and heart failure. So we've been hearing at the national level, policymakers are keen to see a broader NCD or cardiovascular focus in which specific provisions for heart failure may be included. And to that end, I think it is vital that all in this community understand some of the exciting developments at the EU level in recent months as we build towards the possibility of a new EU cardiovascular strategy and how heart failure might find its place within that. And to start this off, we have a pre-record from Dimitris Papadakis, MEP.
Dear all, I would like to thank you for inviting me to the 2024 Heart Failure Policy Summit and apologize for not delivering this speech live today. Cardiovascular conditions are a major health problem affecting millions of EU citizens and are the main cause of death in Europe, responsible for almost 1/3 of all European deaths in 2020. Worldwide, cardiovascular disease is the leading cause of death. In 2019, an estimated 18 million people died from CVD, representing 32% of all global deaths. Heart failure affects 15 million people across Europe, and 1 in 5 adults is likely to be diagnosed with heart failure during their lifetime. It is also the main cause of hospitalization among adults over the age of 65 and places a heavy burden on healthcare systems. Despite improvements in the medical field in terms of managing and preventing heart failure, CVD remains a serious healthcare challenge across all EU member states. There is urgent need to better equip our healthcare systems to effectively respond to challenges posed by the rising prevalence of heart failure and other cardiovascular diseases. Heart failure is a major cause of hospitalizations, costing billions of euros every year across European countries and playing a major part in health inequality between member states. This must change to strengthen the battle against CVDs. There are ever present and common challenges surrounding heart failure, namely developing new clinical roles and care, implementing diagnostic checkups and coordinating research data, as well as challenges relating to innovation of healthcare systems and relevant performance assessments. EU institutions are in a unique position to support progress in heart failure in Europe via EU health funding and policy programs. As member of the European Parliament, I do hope that during the next mandate, MEPs will focus more on that issue and that the awareness and proper debate regarding heart failure will be higher on the agenda. We need to raise awareness amongst the younger generations of the risks of cardiovascular disease in their daily life and the best practices to adopt. With adequate funding and programs, we can achieve the challenge of tackling the entire disease pathway. I give you back the floor, and I'm sure you will have a fruitful discussion at the Heart Failure Policy Summit.
Our thanks there to MEP Papadakis for that fantastic address. So I'm particularly delighted now to move to Professor Bela Merkeli, who is Professor at Semmelweis University in Budapest, Hungary, where he holds the position of Rector. Professor Merkeli will be closely involved, we understand, in the response from Hungary to the proposal for a cardiovascular plan at EU level. But who better to tell us more about that than him himself? So, Professor Merkeli, thank you so much for joining us. Over to you.
Oh, thank you so much. Let me present my thoughts how heart failure can feature in that initiative. Next slide, please. So cardiovascular deaths, more patient affected than those with cancer. And it is true, today cardiovascular disease represents clearly the #1 killer in the European Union, accounting for 1.6 million deaths each year, and with an economic cost of 100 billion euro, more than the entire annual EU budget. The rate of cardiovascular deaths is around 50% in Central Eastern Europe. In average, it's around 37. It has a east-west gradient. Next. Next slide, please. So cardiovascular death rate decreased, but still is high and show clear regional differences. However, the age-adjusted cardiovascular death rate has been decreasing over the years, but it still remains high. and show the regional differences. In the Central Eastern European region, it is approximately 300 per 100,000 per population. Next slide. Among the types of cardiovascular disease, heart failure becomes the leader. It's extremely important. Previously, 20 years ago, the myocardial infarction. Now, heart failure becomes the leading cause of cardiovascular death when the heart is unable to maintain its pump function. Based on the aging population and the etiology of heart failure, such as history of myocardial infarction, heart attack, diabetes, hypertension, obesity, or arrhythmias, it is very frequent. The highest prevalence rates of heart failure were observed in Central Europe, range between 1,100 to 1,200 per 100,000 people. Next slide, please. Heart failure is like a cancer of the heart. It is a progressive disease and it has a very poor outcome. During the course of heart failure, patients have a high risk for sudden cardiac death, frequent hospitalizations, and they have a poor quality of life with severe dyspnea. More than half of our patients die within 3 to 5 years. The average survival was approximately 2 years after the first hospitalization. Next. The main challenge is the heart failure hospitalization, which takes the large proportion of the total hospitalization, around 1 to 4%. The patients stay long in the intensive care unit, and approximately 40% of them will be rehospitalized within 2 months. The average length of hospital stays around 5 to 10 days. However, heart failure hospitalization is a huge economic burden. The annual healthcare cost is up to 25,000 euro per year per patient. Next slide. The priority is a very good medical treatment, and we have additionally new effective pharmacological treatment. If we go back, conventional treatments provide 50% risk reduction in cardiovascular mortality. But now we have additional drugs like ARNI and SGLT2/1 inhibition. Let me quote an example. For a 55-year-old patient, adding new pharmacological heart failure treatments mean additionally 8.3 years in cardiovascular mortality and heart failure event-free survivals, and 6.3 in overall survival. The conventional and the new drugs altogether give us in total 13 years. Next. Early diagnosis and treatment is essential to avoid high failure hospitalization, as the progression from relatively stable status to decompensation with a need for hospital admission is very rapid. We need to follow our patients strictly. Continuous care or monitoring, phone calls, telemonitoring is a reliable way by a non-invasive or invasive methods like implantable devices. Next. Remote monitoring and telemedicine for the early diagnosis treatment is quite essential. We can use non-invasive or device-related or invasive monitoring system. They are able to detect heart sounds, pulmonary impedance, pulmonary pressure, respiration parameters, patient activity, and heart rate. Therefore, by these devices, we are able to detect heart failure progression. Next, please. This is an example how remote monitoring can significantly decrease mortality during a year. Next, please. And what about the cost? By using remote monitoring system to early diagnosis, a significant cost reduction can be also achieved from both the healthcare and the patient side. And last, let me conclude. The next slide, please. So cardiovascular death is still the #1 killer in Europe and worldwide, affecting around 18 million people annually. However, in Europe, the rate of cardiovascular death is decreasing. There are still huge regional differences, the highest cardiovascular death rates in Central Eastern European region. The previously treating myocardial infarction was the most challenging medical task. No heart failure becomes the leading cause of cardiovascular death. Heart failure is like a cancer of the heart. The optimal treatment is essential. Primary prevention, nutrition, lifestyle, exercise, not smoking, stop smoking. Secondary prevention, optimal treatment of diabetes, hypertension, arrhythmias, obesity, atherosclerosis, and valve diseases. In heart failure patients with optimal chronic pharmacological treatment, the most important goal is the early recognition of the worsening of the patient's condition to avoid further hospitalization, in which remote monitoring is a reliable method by improving the survival rate and decreasing healthcare costs. Thank you so much for your attention.
Thank you so much, Professor Murphy, for that fascinating insight. And I think that bodes extremely exciting for the future. And we're all looking forward to the Hungarian presidency and to see what can be achieved in cardiovascular disease. Furthermore, moving on that point, it's a huge pleasure to welcome James Kennedy, who's Public Affairs Director of the European Society of Cardiology, to the Heart Failure Policy Summit. James, I know that you've spoken to the heart failure community on other occasions. A huge amount has happened in the last months with regards to efforts to secure an EU cardiovascular plan. We're perhaps not there yet, but so much has happened. Would you give an update on where we're at and also your views on what that plan can do to advance cardiovascular disease and heart failure?
Sure, thanks, Evan. Thanks very much for the invitation. So in terms of what's been happening, and I like the title of How Can the European Union Transform Cardiovascular Health? I think it's fair to say that we're already doing it. Everything is going in the right direction as to where we want it to be at the moment. And I'd like to point out just a couple of things that have happened only in the very short space of time since we last discussed to evidence that. One of the things that the European Alliance for Cardiovascular Health, which is this informal group of cardiovascular health actors at EU level, that's gone from 3 members just 3 years ago to now 20 members. One of the things that's been tried to demonstrate to policymakers at this election time is that it is possible to run on the issue of cardiovascular health, and that if policymakers put CVH front and center and tackle the myriad problems that need solving, it's possible to get attention from the public of this. And this was tested out in December last year at the first very large summit for the European Alliance for Cardiovascular Health. Can we bring politicians down to make commitments in advance of the elections at the busiest session of Parliament for that term? And in 2 days, over 100 members of the European Parliament came down to make recordings about how they're going to support an EU cardiovascular health plan. Just on Monday this week, there was a sit-down interview with our ESC president, Franz Weidinger, and chairman of the EPP group, Manfred Weber, so the largest political group in the European Parliament, talking about why we need a cardiovascular health plan, why this is going to be front and center, and what needs to be done to make that happen. Over the weekend, on Sunday, we had the German Minister of Health at the German Society of Cardiology Congress announce that there will be a German cardiovascular health plan, and that over the course of an hour pledged his full support for this. So in just a couple of years, we've seen the notion of an EU cardiovascular health plan be nowhere on the agenda, even coming out of a pandemic, to suddenly having the largest political group in Parliament support the notion of a cardiovascular health plan. We've gone from Spain leading the way on national CVH plans to Poland to now having 8 more countries that have either announced or started or fully implemented cardiovascular health plans. So I think things are going extremely well at the moment. Looking ahead to, and Professor Bela Merkeli mentioned, the Hungarian presidency as well, things that are right on the horizon this year. On the 4th of July, the Hungarian presidency will host a full conference on cardiovascular health involving 31 ministries of health to talk about what needs to be done. And at the end of this year, in December, there is set to be European Council conclusions on cardiovascular health. And if just as a point of reference for those unfamiliar with some of the terminology, these council conclusions are the same political instrument that gave us the smoking ban across the European Union. So in terms of effect, think about 27 ministries of health committing to things and then going back home to looking to implement them. So we're in tremendously good shape at the moment. So we're in a very comfortable position of now more worrying about what are the kinds of things that could derail it rather than, how do we really make sure that this can happen? Because I think things are we're in a much better position than maybe we could have hoped to be just a couple of years ago. And there's two things that are front and center of my mind of things that I think we need to be vigilant of moving forward. The first is budget. The EU budget is under tremendous pressure at the moment for factors which I'm sure everybody will be familiar with, mostly the war in Ukraine, pressure on the agricultural sector. So, one of the things that we have to make sure of is that policymakers don't forget the need to preserve health budgets, both at national and EU level, and to ring fence these budgets, or else pay 10 times as much down the road from unaddressed health conditions. So I think that's one particular thing that we need to send a message to policymakers, which is preserve these budgets and make sure that those people who are responsible for implementing these types of plans, such as DG Sante and the European Commission, that they have the staff and the budget they need to effectively implement them. Because anything that we want, including heart failure as part of a cardiovascular health plan, is going to need funding if it's going to be effective. The second part that I think we should be a little bit vigilant of in the cardiovascular community is the notion of a cardiovascular health plus notion, this idea of a CVH and something plan. This is a very short route to ending up in non-communicable diseases plans, which is essentially what we've had for the last 30 years or 20 years at EU level. And this approach to policy of adding in more and more topics is usually what I call policy homeopathy. There's no evidence that it works, and it's based off the misguided idea that by continually diluting something, you somehow make it stronger. And when it comes to NCD policy, we have to be very careful that at EU level, we don't suddenly end up spending a lot of money on what traditionally has been focus groups that usually come to the conclusion that people should not eat too much or drink too much or smoke too much. Rather than looking at what are the pilot projects that help, how can we reduce and tackle these risk factors, what research needs to be done, what registries do we need to support, what education do we need to provide. So I think when it comes to, how can the European Union transform cardiovascular health, we're on our way to a cardiovascular health plan. The question is now, for me, how do we make sure it's a cardiovascular health plan that's going to be able to deliver for patients and those responsible for caring for them? So I hope that serves as, I only had a couple of minutes, so I hope that serves as a brief update, and happy to answer any questions at a later time.
Thank you so much, James. I think a huge congratulations for that incredible progress that's been made. So I think just to summarize here, back to colleagues with, say, HF-specific interests. So governments, over this first course of the session, we've been hearing governments are being sensitized to cardiovascular disease, in particular by a major push through the European Union and some of its political instruments there, such as the Council of Ministers, but others as well. We're seeing a focus on sustainability, including, for example, provisions of telemedicine, access to care in the community, modern therapies and diagnostics, and this wave of cardiovascular plans that was happening already, but it's also going to be probably accelerated by some of the work at the European Union level. So if you are listening to this and you're based in a member state of the European Union, remember, you also have other European elected politicians who likely have already been sensitized to this and may well have actively supported it, who you can be working with. I think it's a great time for all of those who want to see improved heart failure policies to know how we fit into the bigger cardiovascular picture, and also what specifically you need to be asking your government for. So on that note, I'll hand over to my colleague Kirsten, who will proceed with the next part of session 1.
Thank you, Ed. My name is Kirsten Budik. I'm the program lead for the Heart Failure Policy Network, and I'm delighted to introduce the next couple of speakers and the exciting case studies that we will be discussing. First up are insights from the new PORTOS case study that has just been published, that has been evidencing the burden of heart failure. And I think we know there's often a lack of accurate data on the real-world burden of heart failure, and this new study in Portugal addresses this gap by providing current epidemiological data. So I'm delighted to introduce Dr. Brenda Mora. She's a cardiologist from the Hospital Militare Dom Pedro V in Porto, and she's also coordinator for the National HF Societies and Working Groups at the European Society of Cardiology. She will be talking about the case study and what it means for advancing heart failure policy and care.
Good afternoon. My name is Brenda Moura. I'm a cardiologist from Porto, Portugal, and I'm also a member of the Heart Failure Association board. And I would like to thank for the opportunity to be present here at Heart Failure Policy Summit. I will talk to you about the prevalence of heart failure in Portugal, and just to set the stage, this is what we had so far. So this was the EPICA trial. This was published in 2000, and basically what we had was a prevalence of 4.36% of the population with an age over 25 years old with heart failure. So this is quite old data. We know that risk factors are now much more prevalent and the population is older, so it was very important to have new data on the prevalence on heart failure in Portugal. And so this study, the Portos, was run last year. So the primary objective of the trial was to determine the prevalence of heart failure in the population with an age over 50, but we had also secondary endpoints like looking at the prevalence according to age, to gender, and the region of the country, the prevalence of different subtypes of heart failure, comparing the population with heart failure and non-heart failure regarding some characteristics like sociodemographic and anthropometric, regarding the lifestyle and also the presence of comorbidities, and also to determine the impact of heart failure in quality of life. And of course, we characterize heart failure according to ejection fraction into heart failure with reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction according to our actual guidelines. So we had 3 phases of this trial. The first phase was a heart failure screening. All people had the NT-proBNP measure, and they also answered some questionnaires about quality of life. They had their vital signs measured and also an ECG, one lead ECG done. The second phase was the confirmation phase. All the patients with NT-proBNP higher than 125, or those who self-reported to have heart failure, were submitted to an ECG and an echocardiogram. And then there was also an exploratory phase where after being classified as heart failure with reduced ejection fraction, mildly reduced, or preserved ejection fraction, there was also a group of patients that had NT-proBNP higher than 125, but they had not criteria for HFpEF, and so they went through this HFA algorithm to have a better diagnosis. And from the statistical point of view, it was calculated a sample according to the NUTS. And what we had was what we call our mobile unit structure. Basically, it was a truck, and this truck went through all the country. And this truck had a reception, 3 rooms to meet the patients, 1 lab, and 1 echo room. And so in Portugal, we have a bit more than 4,500,000 people higher than 50 years of age. 15,000 were contacted, and we screened 6,189. Basically, then were evaluated with ECG and echo, all the confirmation phase, 2,498 people. So, and these are the results regarding prevalence of heart failure in Portugal. With HFrEF, we found 23 patients, so 0.35% of the population. With mildly reduced ejection fraction, 52 patients, 0.97%. And with HFpEF, 1,061 patients, so a percentage of 15.22. So globally, we found a prevalence of 16.54% of a population with 50 years of age or older. If we take a look regarding gender, we can see that the risk of heart failure is twice more prevalent in women than in men. And obviously, it rises sharply with age, with patients over 70 years of age having a 30% risk of having heart failure. So this is my final slide and the conclusions of this trial. We had a very high prevalence of heart failure, 16.54% of the population. 93% of those patients had HFpEF, and 90% of the patients did not know they had heart failure previously. Thank you so much for your time and attention.
Thank you so much for this presentation. And I think really striking data from what Mr. Lee 3% of population living with heart failure. And it just really demonstrates the sheer scale of heart failure and what takes in about health systems and categorically our health systems. We will now move into part 2 of the session, building the case for heart failure. Please do continue to submit questions in the Q&A box, as we will have a Q&A section at the end of the session. We will hear from a series of experts now sharing learnings from their successful real-world initiatives building the case for heart failure. And to kick this off, we turn first to Professor Salvatore Sommo. He is Secretary in Faculty of Medicine at University of Atlanta, and also the Scientific Director of the Italian Association of Patients with Heart Failure. He will be discussing Italy's vision for implementing chronic heart failure management.
Thank you very much for the opportunity that Heart Failure Policy Network gave to me to attend this very important summit 2024 this year. I really have to congratulate with organizers for setting up this important event. Now, let me talk about the patient's point of view and also clinician point of view together, or how better manage heart failure in our country, in Italy. So, well, we know very well that hospitalization is a big issue for patients with heart failure, since it occurs 4 or 5 times a year, and every time the patient comes back to the hospital, the mortality is going to increase. So this is the problem why the guidelines are recommending to improve patients' engagement in the management in the chronic phase in heart failure, especially in the community. You see here from this slide, there are many ways to optimize patients' management in the community, also making kind of follow-up after discharge with home visits, telephone, and telemonitoring. And this is exactly what in Italy we are making together. Previously, Dr. Borghini from Italian Agency of System showed that we are building, thanks to European Community support, this house of community. These house of community are designed just for the management of heart failure and the chronicity, and it's a way where patients can be managed. And I have the privilege to be part of this consensus we just published on how better manage chronicity in the community. Moreover, I also got the opportunity to work in the Italian government policy for improving telemedicine process in managing patients with heart failure and do rehabilitation clinic. This is a protocol that we set up with our Italian Association of Patients with Heart Failure, where we are able to give the patients a device where the patient is able to monitor every day the clinical parameter, including oxygen parameter, respiratory rate, heart rate, blood pressure. And based on this nurse station monitoring from remote, the patient is every day controlled by nurses. Just in case some value is going to be of alert, the nurses can call the clinicians that can contact by telemedicine program the patients and improve the management. And this is something really important because we are shifting in Italy this kind of approach using telemedicine not only in monitoring chronic phase, but also in rehabilitation clinic. Now we are not using any more long-period rehabilitation after acute phase that always is linked with reduction of mortality because it's going to make patients more involved in their management, but also we are starting to make telerehabilitation at home. after 7 days of hospitalization. As Association of Patients with Heart Failure, as a chairman of Scientific Council, I also improved the management into the pharmacy where the patient can be away. So I really thank you, Heart Failure Policy Network. I think that be an opportunity for me to update our new approach to chronicity phase based on this innovation in our country with the of support of Heart Failure Policy Network, like we did in the last year. Thank you very much for your attention. Very happy to get any kind of questions.
Thank you to Professor Di Somma. So next, we will shift our focus away from Europe and across the Atlantic. And I'm delighted to introduce Mark Baines, who's a long-standing supporter of ours, and also the co-founder of HeartLife Canada and co-lead of the Canadian Heart Function Alliance. And he will be presenting HeartLife's pioneering work in heart failure advocacy, including the milestone publication of the Patient and Caregiver Charter and the recently launched policy framework.
Thank you so much, Kirsten. I appreciate it. Thank you so much for having me today. Good afternoon, good evening, wherever you are in the world. I have 5 minutes to present, and so this is very high level, but all the information is available after the meeting, and you can download the framework. And happy to have any conversations about that. Next slide, please. I'm going to tell you a little bit about the Patient Charter, just as a background for the framework and how we got to where we are today. I'll talk a little bit about the national policy framework in Canada and the work we're doing for policy change and our plans moving forward for 2024. Next slide, please. So why do we need a charter? Really, and what is a charter? It's a national standard of care for Canadians living with heart failure, really cardiovascular disease and any disease. There's over 750,000 Canadians living with heart failure. That number is probably closer to 1 million, really, just with people undiagnosed. There's 100,000 new diagnoses every single year in Canada. And by 2030, heart failure alone is going to cost the economy $2.8 billion. Next slide, please. And usually when we think about Canada, well, we think about universal health care. We think everyone has this wonderful standard of care. Everyone gets this top-notch care in the community and the hospitals, but that actually wasn't the case. What we found into the development of the charter, interviewing hundreds of patients and caregivers from across the country, clinicians, healthcare professionals, nurses, that the standard of care was different for everyone. I myself am a heart failure patient. I was diagnosed in 2008. I live in a metropolitan city. I had access to the best standards of care. But we found that someone like me was the exception and not the rule. So Canada did not have this consistent level of care for people living with heart failure and cardiovascular disease. Next slide, please. So we developed the Patient Charter. Ultimately, again, it's a national standard of care for people living with cardiovascular disease, so they know their rights when they're diagnosed with a disease such as heart failure. But it's also for healthcare professionals to understand how they can treat their patients and caregivers, and policymakers and system administrators to use this charter as a guide as they implement their care. Next slide, please. It's used with industry for training, health systems to develop their strategies, and now as a tool for advocacy and policy change. Next slide, please. With partnership with Global Heart Health, thank you to them to bringing this to the global stage. It was endorsed by 32 groups worldwide, translated into 17 languages, and now has the ability to impact over 64 million people, and even recognized by the World Heart Federation. Our work here in Canada for Effective Voice of the Year. Next slide, please. But that wasn't enough. When you think about how we can impact policy change, we need to do more. We had our patient journey map, we have the Patient Charter, but how do we now implement this into change at a policy level? And this is how we developed the Heart Failure Policy Framework, a national action for change. Next slide, please. Why the framework? A few reasons. One, we needed quantitative data to support the qualitative items in the charter. Policymakers needed real economic data to look at the work we were doing, to then even consider implementing change. And system administrators needed real-world evidence to support our recommendations. Next slide, please. And so, but we couldn't do it alone. We're a small organization, but we're nimble. But our strength is in our partnerships. So we partnered with the Institute of Health Economics with over a year to do data review and data analysis to really build an economic policy document. And these are experts in the field. We worked with leading healthcare professionals, patient partners across the country. And then we also engage with the government relations firm because we're not experts in that space, and we wanted to bring the experts in. And then we work with a creative firm, Creatives, out of Munich, to bring it to life. Next slide, please. What is the national framework? Well, it has background data on the health crisis in Canada, as I alluded to earlier. Next slide. But it really focuses on the economic data associated with heart failure in Canada. 2016, 2017, almost 575 million in heart failure related costs. By 2030, again, it's going to cost the economy almost $2.8 billion. Next slide, please. That data then really resonates with our economists. It resonates with our policymakers. So we provide recommendations then on what we want to achieve. They focus on diagnosis and screening, management of care, and research and evaluation. Next slide, please. For an example, one of the recommendations is on presentation of symptoms of heart failure, you get an NT-proBNP test, something that Aiste from Lithuania will talk about later. Next slide, please. So what does that recommendation do over the years? Well, in a certain period, if there's wide access to NT-proBNP and then handheld echo, for instance, it can save the economy up to $347 million by X. So we have a recommendation, then economic savings. Then we measure success of those recommendations based on the number of people who maybe have NT-proBNP and then reduce hospitalizations, for instance. Next slide, please. And then we also have strategies to fund it. So it was great that we had the recommendations, the economic savings, but we also wanted to really tell our policymakers how we can implement this. So next slide, please. We did a quick summary of it as well, easy handout. I mean, I highly encourage that so no one's reading the full document. Next slide, please. And in 2024, we're partnering with multiple groups across the country, the Canadian Cardiovascular Society being one, who helps set the guidelines for Canada, working with multiple stakeholders, I mean, really to engage policymakers, because again, I encourage people to work together. Partnerships build strength. And then what we want to do is launch a private members bill in the Senate of Canada to really bring a national strategy into law. Next slide, please. In February, during Heart Month, we had government recognition with Senator Yona Martin. We've talked to the Ministry of Health Department, provincially and federally. So this is official Senate statement. And then again, this year we want to launch a private members bill. And in May, we have the opportunity to actually go to Parliament Hill in Ottawa and have a meeting with members of Parliament on the Hill, which is very exciting. Next slide, please. Again, partnered globally and in Canada with some amazing partners, including the Heart Failure Policy Network. Thank you for that. Next slide, please. And here's some information. I mean, I went through this information quite quickly. I had 5 minutes. I think I went over just a little bit, but you can download the charter and the framework and then reach out to me with any questions. I'm happy to have a discussion on how we built this framework for change from a journey map to a charter to eventually the national framework for policy change. Next slide, please. Thank you very much, and thank you for the opportunity.
Thanks so much, Mark. And I think you've put together really some striking economic data that will resonate with policymakers, and we would be keen to talk to you in the Q&A session about this a bit more. And now we're moving back to the UK. One of the key themes of this session is political recognition, and one important part of that is raising awareness of heart failure and its symptoms. And I now welcome Nick Harshon-Evans, who's the founder of Pumping Marvelous Foundation, and Dr. Rajiv Samkanaran, who's consultant cardiologist and heart failure lead at Liverpool University Hospital NHS Foundation Trust. And they will be presenting Beat HF, which is a campaign from the UK raising awareness about symptoms and heart failure.
So thank you very much for the invite. It's great seeing old friends, and being an original from 2015 from the Heart Failure Policy Network. It's great to be still part of that. Next slide, please. So we've only got a couple of minutes to present this, so we're going to whip through this, and there are some real graphical slides which you can have a look at to see the impact of what BeAT-HF is about. And BeAT-HF stands for breathlessness, exhaustion, ankle swelling, and time for a simple blood test to clinicians, or time to speak to your GP surgery, depending on the setting. It's a national campaign, and the reason why we're doing this national campaign is because there is no real heart failure messaging in the public, the general public, and we need to have investment in heart failure, and we need to bring it to the fore, and we need to explain what it is. Next slide. So what we did was we embarked on a national campaign, and we brought BeatHF to the general public. This is Leicester Square in London. We brought it to cities and towns across the UK. Next slide. And this is another big sign-in on World Heart Day, where we were advertising to one of the major underpasses in London. We pushed BeatHF across the major arterial routes, which are the roads and motorways across the UK. Next slide. And here it is yet again at a train station, and it's a major train station in Manchester. And you can see we're talking about BEAT, we're talking about breathlessness, could it be heart failure, simple blood test, and beathf.org.uk. In the campaign we did last year, we attracted 56,000 unique hits to our BeatHF campaign within 2 weeks. Next slide. And this is recently at Manchester Airport, where we hit the 3 terminals across Manchester Airport, where we, as you can see, the size of the advertising, we're putting heart failure right into the face of people and talking about the BEAT mythology. Next slide. Not only that, we also put it across national radio. So we pushed the first national radio BeatHF campaign across Classic FM and LBC. This meant that we reach out to 4.5 million people across the UK, and it was a celebrity narrated national radio campaign. Next slide, please. Currently, we are working in Liverpool, across the Liverpool postcodes. We're targeting areas of deprivation. We have 500,000 targeted adverts across digital audio, which is radio, streaming and podcasts, and that's over a 3-month period. Next slide. And our latest project is BeatHF Hospitals, which basically means that we are looking to raise the awareness of heart failure in the unplanned admission sector, but not just in primary care, but the unplanned admissions. Next slide. But why are we doing this? Next slide. So important to build a positive attitude towards heart failure. We talk about it in a very negative manner. Just the name itself is negative. The understanding of heart failure is poor, it's underinvested, and this directly impacts patients. Time to diagnosis is poor. NT-proBNP is more cost effective than a straight referral to an echo. In the UK, diagnosis 79% first recorded in hospital, and 41% presented with previous heart failure symptoms in primary care. And quicker access to prognostic treatments, which leads to reduced hospital costs and improved quality of life, length of life for the patient and their families. Next slide. And just before I introduce Dr. Rajiv Sankar, we reached out to 16 million marketing impressions with BeatHF. As I said, around 4.5 million radio reach. So we are continuing this program, and Dr. Rajiv Sankar is going to talk to you about a module of BeatHF. Thank you.
Thanks, Nick. So I have a couple of minutes, so I'll quickly summarize, but it goes back to the question Nick asked about why we're doing this. So it's about, even historically, we know that about 80% of heart failure diagnosis is made in the emergency departments and in hospital when patients present in extremis. So Pumping Marvelous are showing the way for healthcare systems as to how we can shift the paradigm of early diagnosis made in the community, but it's also detection and public awareness. So we've conducted 3 out of 12 such events across the country, and this includes England, Scotland, Ireland, and Wales. But we've conducted 3 events, so Liverpool, Stoke, and Kilmarnock in Scotland. And I'll just talk to you about some of the figures for the 1,400 or so people that were screened, basically. But what we wanted to demonstrate that this is possible. We can detect conditions like hypertension, atrial fibrillation. We can do a point-of-care NT-proBNP, and these people can have a prompt diagnosis done. So it's about showing that this is demonstrable. So out of the 1,400, about 30 to 40% had undiagnosed hypertension, about 2% had undiagnosed AF, about between 4 to 6% had elevated NT-proBNP, and out of those, around 60 to 70% have had an echo finding that demonstrated that they indeed have heart failure. And this demonstrates that this program can be done and can be done at scale. And we know that COVID has unmasked a significant problem as well. There's significant backlogs, and there's also a significant cardiac excess deaths. So it's about changing, how we can, screen and diagnose early. And it's not just about detecting heart failure, but also detecting the pre-heart failure conditions. And hypertension is a big problem as well. So we'll be keen to demonstrate the full results from all the 12 sites at some stage in the near future. But it's exciting work, and credit to Pumping Marvelous for leading on this. Thank you.
Thank you so much, Nick and Rajiv. I think it's such a fantastic multi-channel campaign with community screening, and I don't think there's anything quite like this in the world, so I hope others will follow suit. Next, we're moving to our first panel discussion. We've heard from Mark earlier how governments could save enormous amounts of money if early diagnosis of heart failure was fully implemented, for example, via the use of NP testing. And I'm delighted to now introduce Professor Petar Seferovic, who will be leading this panel discussion and introducing the members.
Thank you very much. It is our great pleasure to have the part of such a marvelous event like your summit. We are going to discuss one of the most important topics today in the field of heart failure, and this is natriuretic peptide testing. I'm gonna be joined by the Aiste Štarlaite. She's a Lithuanian Heart Failure Association president, and Professor Kostas Athanasakis, who is in University of West Attica, but still very prominent heart failure analyst. If you can give me the first slide. So I would like just for a few moments to give you the insight in one proof of concept study called Peptides for Life. Next, please. Which we conducted in the area of the Western Balkans, and this is based on the results of the Heart Failure Association Atlas first edition, which clearly revealed the lack of the use of natriuretic peptides in the emergency department, especially in the Central and Southeastern Europe. Next, please. What was important for us is that we designed very simple study in whom the primary objectives were to test the hypothesis that education will improve the use of natriuretic peptides in the breathless patient in the emergency department. And the secondary objective was to compare the diagnostic pathways, final diagnosis and treatment, pre and post-educational program. We call that Peptide for Life's initiative, and the study was done in the emergency department. Next, please. What we did, we designed a limited study, which was done in 10 centers in 5 countries, involving 81 healthcare professionals, 38 cardiologists, 26 emergency physicians, and 17 others. Next, please. So the idea was to include a patient who came consecutively in emergency department with dyspnea. We have also very precise exclusion criteria. And what we did, we monitored in pre-educational group how much natriuretic peptides were used, and then had the significant amount of the online education among the participating physicians. And later on, we conducted post-educational survey, and we find, next please, that the use of natriuretic peptide reveals significant difference between pre and post-educational period. In pre-educational period, the amount of the use of natriuretic peptides in the investigated cohort was 37.7, while on post-educational phase, it was 61.3. So it was clear-cut increase in the use of natriuretic peptides, showing that the education of the physicians who are working in emergency department may be the clue for use of this essential analysis. Next, please. If we look also the final diagnosis and outcome of the patient who identify as a roll-in, it is clear-cut that the education may be the best way how to improve the amount of the analysis we use. What we find out, and that should be mentioned in the meeting like this one, is that we are talking a lot about the natriuretic peptides. However, when it comes to the reality, these analyses were used much less. Thank you very much. And now I would like kindly to ask Aiste, who is the person who made the progress in security, better access to natriuretic peptide testing in Lithuania, to tell us what she thinks. How is the best way to achieve the higher use of this important analysis in the diagnosis of heart failure? Aiste, please.
Thank you very much, Peter, and thank you, everyone. And thank you. I would like to thank the Heart Failure Patient Policy Summit for the invitation to participate today. So in Lithuania, we were very lucky to be a part of the Global Alliance of the Patient Organizations Global Heart Hub, who actually took a framework that Mark just spoke a couple of minutes ago on the Canadian Patient Charter, and developed International Heart Failure and Patient Caregiver Charter, which again, the patient organizations were able to take this policy document and localize it on a national level. And this is exactly what we did in Lithuania. So we took the document, we localized with Lithuanian data. It speaks about patient responsibilities and patient expectations. And this is the first document as such in Lithuania focusing on heart failure. And what I did as a leader of the patient organization, I actually invited all the key stakeholders in Lithuania for a roundtable discussion to introduce the Heart Failure Patient and Caregiver Charter, and as well to highlight the heart failure burden. One of the key major issues that we currently have in Lithuania is the access to care in heart failure. And with this approach, Lithuanian Cardiac Society has been already working in having this NT-proBNP testing available for the people in primary care. But things did not move until the patient organization stepped in. So it was very powerful to hear the positive response of acceptance and availability of NT-proBNP since last year, since January the 1st in primary care, for free for everyone who are short of breath. And this is for two cases: one, to identify heart failure, to early diagnose, and for second case is to get them, as we call it, a green corridor to reach the cardiologist as quick as possible. It's been more than a year now, and there are some learnings, of course. And one of the key learning here and lack, if I could identify like this, is the education. Education of the society, education of the primary caregivers as well, because cardiologists, they know well what NT-proBNP is, how it works, and how to use it. But there is a major lack of education for the rest of the community. And I would finish my speak here, and if anyone has any questions, I'm looking forward to answer those.
Thank you, Aist, very much. We know that Lithuanian Heart Failure Society is very active, and that for, I may say, as a past president of Heart Failure Association, that you did a lot of new stuff in the last decade, which are on the forefront of the development of heart failure, and this is probably the moment to thank you for that. We have with us also Professor Kostas Athanasakis, who is the professor of the Health Economic and Health Technology Assessment. And so Kostas is very important for us because he's looking at the things from another angle, giving us the possibility to see how we can improve ourselves and get more to the goals we had. Kostas, please.
Thank you very much, Petar. Thank you, everybody, for giving me the opportunity to share some thoughts. In this case, equitable access starts with reimbursement. So I'm going to try to walk you through how NP testing was actually came to be reimbursed in Greece, what we did and how we succeeded to provide equal access to everybody in the country. Now, this journey starts back in 2014. Back then, we did an investigator-initiated study trying to find out the actual cost of a patient with heart failure when being hospitalized. We did find the cost per episode, actually, but we also found quite a connection between NT-proBNP and the cost of episode. Now, NT-proBNP at entry was statistically significantly correlated as a predictor of the total cost. And we decided to take this further and build evidence on whether this would be of value, this indicator would be of value for the system. Now, bear in mind that all this takes place back in 2015, 2016. It's the pre-HTA phase for Greece. When you do health technology assessment, then there is a process waiting for your question. But when there is none, then you have to build awareness, you have to build advocacy, and to get people persuaded that in order to reach to hear your claim. So we did this by actually providing context in all the key actors in the system, and we did this with a series of research and engagement activities. First of all, we tried to build evidence on the economic value of NP testing. We did a systematic review, and we found out that savings of 7 to 34% of the actual patient cost can be achieved with the use of NP testing. This was a systematic review data, but we also tried to produce local data as well. So we did a budget impact of the use of NT-proBNP in Greece to provide local data. In this study, we specifically used an expert panel consisting of local experts who provided data, provided insights, but also this created an engagement with the experts and opinion leaders who also became ambassadors of the study and its results. The results were, of course, positive for testing. We then organized a series of scientific meetings to present the results, and we took part in a series of dissemination activities, also with some great literature, so as to make the issue visible. In later on, we engaged with policymakers that could also understand the rationale behind equal access for everybody, and persuaded that to test this from a social security perspective would be meaningful. Following the maturity of the discussion, a positive decision on reimbursement was achieved. We provided evidence that this was 20 euros well spent, and I do believe that this is commonly acknowledged in the Cardiological Society in Greece, as well as the social insurance as well. We don't stop here. We currently work on future aspects of this work. We try to change the paradigm and make use of point-of-care systems, as well as trying to make use of such approaches for the new types of care, like hospital-at-home types of care, through NT-proBNP testing. Again, we will produce a series of data, local data, and engage in talks with stakeholders trying to raise the cause. Thank you.
Thank you, Kostas. As I thought, you gave us an excellent direction where to go. However, as you pointed out, I think this is the ongoing process and we need to work more on this because every country at several levels needs to have NT-proBNP testing. Thank you very much. Thank you, Aiste. Thank you, Kostas. And we'll continue our summit.
Thank you so much. And we'll now come to our final panel discussion, which will be led by Ed. So I'll hand over to him.
Thank you, Kerstin. Huge thanks there to all our speakers and congratulations on what was achieved, as Petar Seferic has already said. So I'm very pleased to be joined now by Hans Martins, who is president of the European Association for Value-Based Healthcare, and he'll join Professor Athanasakis to discuss some of the content that we've covered. So Hans, again, thank you so much for joining us. If I may turn to you. You're somebody who has been working with policymakers your whole career in projecting the value argument in health. From what you've been hearing today, how can the heart failure community engage policymakers more effectively?
Thank you very much for having me here, but I think we have heard quite a lot of references to what I really wanted to say to answer your question, because I think what you really want to do if you want the attention of policymakers is to talk to them about what concerns them. And I think the overriding issue today is huge problems with the resilience of the European model of health systems that we'd like to have, in particularly in Europe, with equal access for everybody. It is because of the demographics, but it's also other factors. Demographics, of course, then, let's say, is hard for the health system in two ways. First of all, we lack young people for doing the workforce and to have the jobs in the health sector, but we also have a lot of elderly people with many comorbidities. So the systems are cracking, waiting times are going up, people get frustrated with policymakers need to address this for the sake of patients, for the sake of the system, but also for the sake of themselves, because this is going to be, it will always be a big issue when election day comes. And I think the chronic diseases are especially important because they often follow with the aging of people, and that increases the burden of the elderly people on the health system. But life is not just about long life and life expectancy, it's also, and maybe even more, on healthy life years. And I think we have touched upon this quite a number of times during the session here today, but we actually have a relatively low number in many European countries of healthy life years. And if we can bring that number up, it will be good for patients, but it will also be good for society as well. And this is what we should tell policymakers. And that's why prevention is so important. So it's not just about cure, it's also moving from sick care to health care. Early detection of NCDs, we heard a lot of brilliant examples today, creates more value for patients, but also for society, as we just heard. And the value creation is not just about patient outcomes, it's also about the societal economy, and therefore about saving, if you like, or make the systems more resilient in the medium to long term. And of course, prevention should not just be for the privileged or for the illiterates and so on. In order to cover the population broadly, there needs to be created a tradition for prevention, and therefore a lot of the campaigns we heard about are very important. But it also needs to be done in a way that's open and easy for people, so not on distant big places, but close to people. And then don't forget that when we have the diagnosis, there is also, and I don't think we discussed that very much today, but there is a need then to set out the optimal pathway for patients. And I think there's a revolution maybe on the way here by including the use of artificial intelligence. But that is another discussion. But it's not just about the detection and diagnosis, it's also about the optimal pathway for treatment. So therefore, I think it's a good idea to broaden the alliance that we are talking about here today, not just about clinical qualities, but also to look into how the system can be organized to get closer to people, to ensure more equal access for everybody, because that's a part of this European model we want to preserve, But also, if we want to reduce the cost of heart failure and other NCDs, this is a good way forward. And then, as it was mentioned, also talk to the patient organizations. They have a lot of credibility. So these would be my advice set.
Thank you, Hans. I wondered also if you might comment on one of the stakeholders that we've possibly not talked a lot about today, or perhaps, for example, insurers or other non-political but nonetheless important decision makers in the healthcare system. I know you have some experience of working with those. Would you be able to share any thoughts on?
Yeah, but just say that it's different from country to country, you know, because if you have a national health system and the private insurance is an additional one, I suppose the payers here are the finance ministries, which again are under the political hat. But when it comes to the private payers, if I may be very direct, I think the education needs to be primarily to not focus so much about cost, but focus on the kind of value that we create. And also let them feel that they bear a responsibility for saving the health systems as such. And I think a lot of them actually do so. But I think this is an important message. But it depends on the systems where you are operating in.
Thank you very much. Kostas, turning to you now, you've been working to drive to promote debates on sustainability of healthcare systems as part of your role in the Partnership for Health System Sustainability and Resilience. What would your advice be to heart failure advocates? How can they connect better to the sustainability debate?
Yeah, it's true that I had a fantastic privilege to take part in the Partnership for Health System Sustainability and Resilience, where I led the country study for Greece, and later on, I joined as one of the 11 members of the EU Advisory Board of PHSSR. This board was convened in order to make high-impact health policy recommendations to EU institutions on critical topics that will help strengthen health system sustainability and resilience. Now, the expert board published its first study back in November. It was presented to the European Parliament. The report focuses on the management of NCDs and the need to intervene early in order to control future morbidity and secure sustainability and resilience. All those are available at phssr.org. So, in this case, heart failure is a great example of this practice. It's prevalent, it's highly prevalent actually. It induces a high disease and economic burden, is set to increase in the future, all those types of burden. But most importantly, it's a disease where you can intervene early and produce important results, both from the disease burden aspect as well as from the economic and productivity aspect as well. Now, in this process and in the partnership premises, heart failure advocates can connect with the partnership, in my opinion, in two major ways. The first one is connect and provide best practice examples. In other words, use cases of how interventions towards heart failure can improve sustainability and resilience. This session has been full of such great ideas that I think that we need to push further on. The second way through which heart failure advocates can also connect with the partnership is by creating interaction with stakeholders. This is the key essence behind PHSSR as well. And by interaction, we mean workshops, events, literature, in order to promote the discussion on sustainability and resilience with a specific focus on heart failure, with a specific focus on a huge issue of today and of tomorrow, of course. Thank you very much.
Thank you so much. Hans, I think you need to leave us, and thank you. Really appreciate you joining us. I believe we have with us Professor Salvatore Di Somma, who has since joined the summit, and we have a question for you. Following on from your presentation, perhaps you could tell us a bit more about the telemedicine program that you've been setting up in Italy, and in particular, how you instigated the program with pharmacies to promote early detection of heart failure. We're aware that there's been a lot of interest in pharmacies and task shifting in the heart failure debate, and perhaps you might give us some further commentary.
Thank you very much for these great questions. That allows me to complete my speech that was for 4 minutes, so was not enough, but just address by one, the first one. So telemedicine was a great opportunity during COVID to start monitoring patients at home, right? Based on that, our association of patients that I have the honor to lead in Italy were really coming to the idea to be connected because they didn't like to go to the hospital. Now, based on that, like I show in the slide, we organize a kind of a system where the doctors select the patient need telemonitoring, right, after discharge from the hospital to avoid the hospitalization. What is important to have a nurses station that are for 24 hours a day monitoring the patient collect the data, but what is important, that some alarm can come, I don't know, the change from saturation from 98 to 90, right? So the cardiology from remote can intervene, and what is important that the patient is aware. So telemedicine, a fantastic opportunity. Now I got the opportunity to lead Italian telemedicine program for the government, and we are going to have guidelines on how to manage. So the three ingredients would be patient's involvement to understand telemedicine is not replacing clinical visit. It's really important patient understand that you are not going to see the doctor less time. It's simply improving the connection, not only between patient and doctor, but between doctors, GPs, specialists, patients, other specialists as cardiology are linked to telemedicine. So the secret is, first of all, patient engagement. Secondly, nurses skilled. I am leading now a program for nurses to be skilled with the telemedicine. And lastly, it is really important you have to measure. So we were able in Italy to reduce 35% inappropriate visit to the emergency room of patients because we were able to intercept the patient's need. So we sent at home a team of people doing echocardiography from remote technologies and NT-proBNP at home. So this was the way for the telemedicine for patient go at home. Now it is a role in Italy because you asked me to talk about Italy. Now, our association, just to address the second question, is very focused on the community, on the chronic disease, because we cannot afford any more patients coming to the hospital, right? So this is the way why in Italy we have this organization that Borghini presented. We have this house of community where patients association are there, and even the patient can go to the pharmacy to make a kind of a questionnaire. The pharmacy has the role of a screening of patient, and then based on this score on the pharmacy, they can do NT-proBNP, they contact the clinician. So I just want to summarize that. Thank you for these questions that allow me to see that in Italy, I am contributing a lot with the Italian government to use PNR money from Brussels to increase community effort to take care of patients using telemedicine, GPs, and pharmacy. And this is what I think will be the future. So we are not going anymore to increase hospital beds. We are trying to balance. But I just want to remark that still the value of networking between cardiologists in the hospital, other specialists, nephrologists, COPD pulmonologists, patient association, shareholders such as nurses is crucial, and telemedicine can achieve this goal. Thank you again for these good questions that you asked me to address.
Salvatore, and I think any decision maker should be pretty swayed by the 35% reduction that you said in inappropriate visits. On building on that point, we have a question here from the audience, Ambrose McLaughlin, who asks, in a sense, across two questions, what about other societal leaders, so employers, civic leaders, trade unions? I'm going to throw that open to the speakers who are with us. Would anyone like to comment on going beyond the political leaders to others if we're truly serious about a strong coalition for heart failure going forwards?
There's one thing, Ed, because I need to go in a few minutes. If I may just say, I think a lot of employers actually see the interest because for them it's also creating a lot of value. You know that people are coming back as soon as possible. You know, to the jobs and so on and so forth. So, in many ways, health at the workplace, which also means introducing a number of healthy ways of living, healthy ways of working are actually being introduced. And I think the trade union should back that up as well. I don't think we see a strong engagement in this at the moment, but if we try to talk to people about the common responsibility for keeping the resilient health systems and keeping the European model of health systems with more or less equal access for everybody, I think they would understand that there is a big role here. So maybe your the Heart Failure Association here should try to work a little bit more with them and tell them about their responsibility.
Thank you.
Just a thought on that. Bear in mind that 40% of total morbidity burden is behavioral burden. All right, it's on behavior. So all those types of leaders in the community can also influence people towards healthy behaviors by giving an example. However, there needs to be a coordination of the activities that will take place, and this falls on the hands of state leaders, right, on the countries, on the leaders of the system. Those are the ones that have to select on the basis of a set of criteria the proper, let's say, interventions or the proper behavioral interventions or the proper programs, and then to be followed by community leaders. I think this is hugely important, especially in our times.
Thank you. Petar Tavarik.
Yeah. It is very important to understand that we are dealing here with two sets of the problem. One set is the set at the European level, and you know that European Society of Cardiology has its own, let's say, part in Brussels, trying to do something. And as I spoke several times with that, it was not too successful. However, as it was mentioned here, Heart Failure Association of the ESC, through Heart Failure National Societies, did a lot of good things, raising the level of the knowledge, awareness, and patient connection with within the field of heart failure. And this is the part which can give us the possibility to start with a thing like professionals in heart failure, allowing us to get closer to the patient and stimulate the patient group to talk with the legislation. So this is a key point. I know that it's not easy. We've been trying this for almost 10 years, but I believe that this is the way to go.
Thank you, Petar. Aiste, I believe you're still with us. Maybe you'd like to take that one on the future direction of patient advocacy globally, but also in Europe. How do we build and strengthen HF advocacy as an essential component of engaging decision makers? Perhaps we'll come back to that one, Aiste, if you can. We also have another question on the pharmacy side. So again, one here on will pharmacy have an increasing role to play in community medicine, and also on echocardiogram. So we talked a lot about obviously securing access to NT-proBNP testing. What about fast tracks to echocardiogram or possibly mobile handheld? I wonder if anybody would like to on the panel.
We have a real data in the field of use the echocardiogram and the BNP comparatively. And what can be said, it's all depends on the part of Europe. However, just in the few countries in Europe, I think it is UK and this is Germany, NT-proBNP are used more to make the early diagnosis of heart failure. In most of the countries, the echocardiogram is a first tool which gives you the insight, is this patient heart failure patient or not? So this also demonstrates the possibility that heart failure patient is first seeing all cardiologists or general practitioner or intensivist. So we had longitudinal and vertical analysis of this problem, and what we find out, and this is nothing to do with the time cardiologist, but the diagnosis of heart failure was mostly done by cardiologists at the early stage of patient presentation.
Thank you, Petar. Kostas, over to you.
Yeah, just a more general comment on this, on the role of health professionals in the future system. We expect, as you all know, I'm pretty sure, quite a big shortage on the required numbers of health professionals in our future system. And this, of course, due to many reasons. The only way forward in order to ensure sustainability and resilience in the system comes through task sharing and task shifting between health professionals. So we have to make extensive use, the best use possible of our human resources in the system. And of course, pharmacists, especially community pharmacists, being so close to communities and people, do have an important role to play. Also, other health professionals do have an important role to play as well.
If I can just,
Yes,
may I add?
Yes, please.
Yeah, if I just can complete what I'm talking about, of course, Italian experience, right? But I think that at the end of the day, our experience and now our roles in Italy, what I presented has been already prepared as a kind of guidelines for Italian government. I was chairing these two area of telemedicine by the pharmacy and also by echocardiogram and NT-proBNP at home. Now we can do NT-proBNP on, let's say, on point of care with a finger stick, like glucose for diabetes. This is available now, and we are really thinking that we need education. Education is including patients first of all. Then, like Petar said, they can speak with the decision makers and doctors. I think we need also to improve patient doctor. We should move from the hospital the knowledge on the community, including patients, patients association, caregivers, GPs. So we have to move in this sense to really work differently. So the pharmacy is one of the pillars of this new version of health system. COVID showed us we cannot go anymore for hospital-based medicine. Hospitals are really important, but they need to take care only of severe patients, only of acute heart failure. For the rest, I don't know in the other country, in Italy, after COVID, we had a 30% increase of emergency room visits, especially patients with heart failure. So this is a system that is going to improve patients' outcome, reduce mortality, and also cost related. So this is the way that patients can talk with the decisions together with us.
Thank you, Salvatore. We're nearly at time, so thank you all so much for staying. But before we go, I stay. It'd be great to have an answer to that question about the future of patient advocacy in Europe and how we grow it.
Thank you very much, Ed, and forgive me, I had to step out for a few minutes. Answering that, I see a really a great opportunity for the patient organizations to actually step in and be that advocate and be the leader in the advocacy. And of course, with all the education and patient empowerment and patient organization empowerment, including them as an equal stakeholder from the beginning till the end in the processes, in decision making, I think it's crucial here because we always talk about the patient centricity, and not all the time we really take that feedback from the patients and input from the patients. So it's very important to have that opinion in and to lead by that.
Thank you so much, Aiste. And I think on that note, as you said, what I think is so exciting about today was both the realm of the possible that we see advancing. There'll be more about that on Thursday in part 2 of the summit. Where are we at? What can we now achieve through best practice prevention and care and heart failure? So many more excellent speakers to come, working at the ground level as well, and other exciting on-the-ground projects. We were hearing today about real-world decision makers at the most senior level, talking about heart failure, talking about how their approach to cardiovascular disease is changing. I think that's a huge opportunity for us all to understand that, to think about how we're going to project heart failure into that. What's the role of HF? What's its value argument? How do we merge that with other cardiovascular conditions into that coherent picture? And I think just so much to play for with the direction of travel that we're seeing at the EU level, and this explosion of advocacy into which 15 million people, or likely more, according to colleagues in Portugal, living at the moment with heart failure, or the millions more who may do in the future, will be counting on us to ensure that voice is heard. So finally, our massive thanks again to the sponsors for the summit, to all the speakers who gave their time for free and 2 hours of their time, and to all of you who have given your time to listen to and take part in the summit, or to share news of this on the social network. We really, really appreciate it. As I said, one more to go. So please help us out, spread the news, and I hope to see you all there. And thank you again so much.